So, good morning, everybody. I'm Mike Morrissey. I'm Head of European Policy at MSD since the beginning of this year. Previously, I was CEO of the European Cancer Organisation and COO of the European Society of Cardiology. And this session is a very special session because we'll be looking forward to the EU's Cardiovascular Health Plan, which we hope, pray, expect to receive from Commissioner Varhey in December. And we're going to be combining looking at what should be in that plan and giving the Commissioner a bit of advice from our panel of experts here. But we're going to also be looking at the Beating Cancer Plan and what lessons can we learn from the implementation of the Beating Cancer Plan that will help us and help the Commissioner with the delivery of the cardiovascular plan in December. Please be ready to give your questions. We've got Sophie Miller, our young Gasteiner from the European Society of Cardiology, sitting at the news desk. So online you can put your questions to Sophie and she'll pick some out. We'll also be having a hands up moment later in the session for any questions that you have. So we've got a great panel of experts that I'll be introducing you to later. But first of all, let's hear from Commissioner Oliver Varhey.
Thank you very much. I think you have heard me speaking already way too much today and yesterday, although I have a speech. Of course, it's a very eloquent speech prepared by my colleagues in the Commission. I'm not sure I need to bore you with that. Okay. Let's open a discussion. And let me tell you what is the background against which we are working and against which I think we should act together. Because, yeah, the Commission come up with whatever plan, but it should also have some impact on the ground. And to me, the big question is, are we going to have an impact on the ground, yes or no? And in this design, this is where I'm really looking at you. If there's something I want to get out of this discussion, is how do I design it in a way, or how do we design it in a way, that it will have an impact. Because the numbers are clear. We know public health figures. Still more than 33% of all the deaths in Europe is cardiovascular related. We're talking about roughly 5.3, 5.5 million people a year of premature death. And most of it is preventable. Most of it has nothing to do with your genetic composition, has nothing to do with faith. It simply has got to do with all the risks that you're taking in your life, basically, if I want to oversimplify it. We have seen that, of course, the tremendous cost as well on the society, but it should never be approached, at least to my mind, it should never be approached as a cost issue. It should always be approached as saving lives. Because if we just cost factoring, I think that we're not doing justice to the problem that we face. Because the problem is getting larger. That is my fear. And that's the second big shocking part of this whole equation of the cardiovascular health in Europe. If I look at the young generation, the numbers are horrifying. We have 20% of the young generation, on average in the EU, overweight. And we have anything between 20 to 40%, depending on the member state, of the young generation overweight and or having diabetes. This means that this generation, in 10 years, they are all going to be sick. They will all have a cardiovascular condition. We never had that before. Never. And that generation is going to be in their prime years then. They would be, taking the society on their back as workforce. So my very simple question to myself was, when looking at these numbers, who is going to work? Who is going to run the society? As simple as this. And if I look at everything that we see as risks, to be frank with you, we know everything. We exactly know what the risks are. We exactly know what would need to be changed. So let's change it. We know why our children are overweight. We know why diabetes type 2 is picking up so drastically with them. We know exactly why the older generation have cardiovascular conditions. We know all the root causes, so are we going to address them? That's the big question to me. The other big question is that in public health policy we have been going forward in terms of improving life expectancy, yes. But since the end of the COVID, it's not so evident that we will be able to continue with that. Yes, the numbers are still improving a bit, but not as much as they used to. Plus, we see the alarming figures related to obesity, related to smoking, vaping. We see in relation to diabetes. So the warning signs are out already. So how do we then influence the choices of people making? Because it seems that we don't. It seems that we ran out of steam in terms of influencing personal choices. So we need to make it much more personal, relatable. This is why things like know your numbers, we discussed it last night. Everybody should know what is the level of cholesterol, what is the BMI index, what is the blood pressure, and what is their glucose levels. If you have 3 of these out of the normal, you should immediately go to see a doctor. But most people don't even know their numbers. So we should work on that as well. So here I think we have big ambitions with the cardiovascular plan, and yes, it will come towards the end of the year. But we need now input. We need input. What would be the most effective and most impactful way of addressing this? And I talk a lot about technology, I know, but technology will be the fastest deployable tool in the cardiovascular. And cardiovascular could be the champion of using these new technologies and improving the public health outcomes the fastest. If we use them cleverly in the plan, which we will try to, personalized predictions, personalized medicine, personalized prevention strategies, they're all available by now. Based on big data, artificial intelligence, if we can bring it down to a personal level, for example, at the level of family doctors or pharmacists, to create this self-attention, this being at risk image for the citizens themselves, so that with their biology they can translate the actual risks to their own lives, maybe we can achieve more. But again, I'm here to listen rather than to give you ideas.
Well, thanks for that opening, Oliver. And well, you want to listen? Here are a bunch of experts that are here to give you advice. And what I've asked our panel to do is to give an opening 3-minute elevator pitch of what they think should be considered by the Commissioner in the cardiovascular health plan. And we're going to start with Professor Susanna Price. Susanna is a leading acute cardiologist based in London. She's Vice President of the European Society of Cardiology and Chair of their Advocacy Committee. Our first elevator pitch from you, Susanna.
So thanks, Mike, and thanks, Commissioner, for giving us the opportunity to speak to you, and thank you all for being here today. So I'm a cardiologist and an intensivist, and I spend every day of my life trying to stop people dying. So when I hear cardiovascular disease is the biggest killer, that to me is the biggest opportunity to prevent death and prevent morbidity. So I see opportunity to change, particularly with premature cardiovascular death and morbidity, which we know a large proportion is potentially preventable, provided we provide the appropriate tools to the individual and systems of care. So I see opportunity here. And you spoke about knowing your numbers. I mean, we all know the numbers to unlock our mobile phones. I mean, pre-pandemic, I would have said we all know the PIN for our cars, but I don't think people do now with contactless. But you do know your numbers for your phone, and we should all know our numbers. You can't tell from the outside whether somebody is at risk. You need to know your numbers. So you need to know your cholesterol, your sugar, your BMI, and your blood pressure. And that should be the norm, not to blame, but to give agency to the individuals. And then to leverage those numbers to give real insight on a personal level using artificial intelligence. So it could be, and we use this all the time, so cardiovascular medicine is, I agree, synonymous really with AI. So we have the wearable technology, the atrial fibrillation detection, so we can move from chance encounters to detect to actually planned intervention and prevention, which I'd very much like to see, but also very much more targeted, so advising one size doesn't fit all, so really personalized medicine, and also targeting intervention, so at a system level, which areas need most intervention, and then measuring the impact of what you've done so you can really do what works. So if I were to say anything, if we want to really move things with cardiovascular health, if we do, I think we need to also shift blame from the citizens individually. It always descends into a blaming people, and I don't like that. I think there are system risks as well as individual risks that need to be addressed. It's not the citizens' fault that they're getting overly sugary drinks, ultra-processed food, being targeted by tobacco and vaping. That's not sort of personal choice or individual strength of choice. Actually, that's down to policy. So I'd like to see a look at system risk rather than just individual risk. Knowing your numbers is extraordinarily powerful on an individual level. If I know my numbers, then I can act. At a system level, if we know numbers, then we can plan, which is phenomenally powerful. And artificial intelligence is absolutely where we should be going, but it has to be equitable, it has to be ethical, and it must be transparent. But if we can do that, then we can move from surviving cardiovascular disease to preventing it.
Commissioner, I saw you nodding through Susanna's pitch there. Any quick response to what she said?
This is a very strong confirmation of where we are thinking as well. Especially, I like that you also list the risks that we consider to be the most risks: high sugar, high fat, high salt content, ultra-processed food. We see with the young generation. This is what is doing the damage. It's pretty obvious. So we will have to do something about it, I'm sure.
So now let's get the patient voice on this, and we're very fortunate to be joined by Susanna Palkkonen, who's Director of the European Federation of Allergy and Airways Diseases Patients. I think I got that right, Susanna. Welcome. Thank you for being here to represent the patient voice. Your pitch to the Commissioner.
Thank you very much. It's an honor to be here, and especially for the first time being involved in a discussion on cardiovascular, because there are overlaps. So my first message is that heart and lung, they depend on each other. Each breath and heartbeat, they cannot exist without each other. So that's the first message. And then lung health is actually greatly contributing to cardiovascular health in fact, poor lung health, such as chronic obstructive pulmonary disease, it's causing cardiovascular emergencies. So this is a connection, and that's why we see very much from our patient community that this, the cardiovascular plan can bring even more benefits to health in Europe than maybe you initially were planning for. So congratulations for that. One key element that is currently missing from the draft plan is the opportunity to prevent respiratory infections through vaccination, but also through other things. This is a joint benefit for respiratory diseases, but also cardiovascular disease and many others. So this is something that could be promoted also as a prevention measure. And there are also analogs to the cancer plan, which is being implemented because there is issues about the actions about the vaccine preventable cancers. So these cross benefits will maximize the impact of the cardiovascular plan. Then it was already mentioned that there are common risk factors to both cardiovascular and respiratory health, especially from tobacco. And you mentioned yourself vaping as well, and this is the young people. So let's make sure that the regulation on tobacco and modernizing the tobacco products directive to include vaping as well really happens through in your mandate. This takes a lot of balls, and when we have been hearing from you around these days, you are the right person to kick this in action. Then in the cardiovascular plan, you're planning the systematic health checks, and we would like to ask that in those health checks, because of the link between lung health and cardiovascular health, that you also consider implementing lung health check through spirometry testing for people at risk because of the cross-benefit in cardiovascular. And if you have time, in the other building, there are lung health checks through spirometry happening just now and throughout the day. So you are very welcome. We would love to have you. Then, I mean, those were the main messages, and thank you very much for this opportunity. And the patient community in our network, they are already doing cross lung and cardio actions, evidence-based actions on the ground, including here in Austria, our member association, Austrian Lungen Union. So they are your allies on the ground as well. If you put lung into the heart plan, we are there. Thank you.
Super, very interesting, Suzanne. I particularly liked the reference you made on vaccination and the opportunity the cardiovascular plan has there. Any quick reaction, Oliver, to what Susanna said?
I picked up the one on vape because for whatever reason in the public it is not presented as a danger yet, but we already see the public health impact. Again, young generation, I mean, for example, you have the Czech Republic, more than 25% of the youngsters are vaping or e-cigaretting. And the health impact is already there. This is a number which is higher than the average in terms of EU adults smoking. It's a horrifying figure. And in that, I think the first move that we made was a very important one. And that is the amendment and the raising of the excise duties on tobacco and nicotine products. And this is also a first strong signal in terms of the direction of travel of our policy. You have seen that in that we will raise the excise duties on these new products to the exact same level as it is for the classic tobacco products. And we will need to continue in that direction. Of course, it's very important to have a confirmation from the lung experts that we're doing the right thing. Thank you.
Thanks very much, Commissioner. So next we're going to hear from Professor Fausto Pinto, who's a leading cardiologist from Portugal. Fausto is unique in that he is a former president of the European Society of Cardiology and a former president of the World Heart Federation. So welcome, Fausto. Thank you for being here. So here's another expert for you to listen to, Oliver.
Well, thank you very much for the kind introduction, Mike. Commissioner, first of all, thank you so much for supporting the Cardiovascular Health Plan. That's something that we in the cardiovascular community have been looking for many years, and it's something that we really appreciate, and we're really very happy that finally we're going to have it. My pitch is going to be for research and innovation. If you look at the last 30 to 40 years, the advances in cardiovascular science have been contributing to about 80% of the expansion in life span in Europe and across the world. So a lot that we are enjoying today was because of all the developments, all the research that was done in the cardiovascular field. The other aspect that you mentioned, and I think that's something that we keep saying, we know a lot about the risk factors, we know what the risk factors are, we know what we should be doing, but unfortunately there is this gap. There is so far our incapacity of translating what we know into real action and into the field of the population so we can be successful. So I think here we do have to do more research, for instance, on implementation science, on some aspects that have to do with the fact that we need to improve how we can reach out to the populations. But we should not neglect innovation, and we should not neglect the support for research that in Europe we are facing for the last few years, as you well know, big competition. So if you want to be, and I do know what you think about it, but if you want to be competitive, if you want to be at the forefront of science in all the different fields, but particularly in the cardiovascular field, then of course we have to support that. And we have to support implementation of that at different levels, and I'm sure that you have that in mind. And I was actually very happy to see also the Biotech Act, because that links with, of course, with what I'm talking about. And I do know that you are a strong supporter of biotechnology development and how Europe has to play a significant role, because we have big competition from the US, from China, from other places. Of course, in the global world, we look for the developments in everywhere, but in Europe, in my view, we have to be stronger. And that means that from the support that the Commission can give to the scientific community to develop more, to further be more strong in the research that can be done, and then in the implementation of innovation, that's something that I'm sure that you will support that, but that's something that I will really, as part of the scientific community, would like to pitch, let's say it, at this time, and see the future, a stronger Europe in science, all science. Of course, I'm a little bit biased for cardiovascular, and that's what we're talking about, but that's something that we should not neglect. Despite the fact that we already know a lot, you know, the concept of knowledge, you know, the more we know, the less we know. So, so it's very important that we continue to do that sort of support, and thank you again.
Thanks very much, Fausto. And Fausto mentioned there a couple of important buzzwords in the Brussels bubble. Competitiveness, of course, is much talked about, although we haven't seen a huge amount of action on that so far. And also mentioned the Biotech Act, which I know you're taking a special interest in getting out as quickly as possible. Any comments on what Fausto said?
Yeah, fully agree. The cardiovascular area has a huge potential in terms of creating already the new landscape for the health ecosystem or the health industry or the health sector as such in Europe, for two reasons. One is that this is the most researched area. So this is where we know the most. And that makes it easier now to relate this to this technological breakthrough that we see emerging. So I think the cardiovascular, in that sense, is going to be even a bigger success in terms of patient outcomes than what we see in the Europe Beating Cancer Plan, if we do it right. And that leads me to my second point, which is something I've learned from a former German health minister at the beginning of my mandate, also coming from your society, which is a really mind-boggling figure. That if we address the cardiovascular problems, not all of them, but most of them, so if we change the basics in terms of cardiovascular health in Europe, we could expand the life expectancy by, on average, 8 years for our citizens. 8 years. As opposed to cancer, where we can, if we are able to treat everything and we will know everything with 1 year max. So we have no time to waste.
We all agree.
That's great. Well, next up is an expert. I'm trying to think which hat to describe that Pernilla has, because Pernilla Gunther has many hats, as many of us know. She's a former politician. She's a former Swedish MP. She's a member of the EU Cancer Mission Board. And I guess most importantly for this debate, she is a cancer survivor and a heart failure survivor. So listen up, Commissioner. Pernilla, over to you.
Thank you so much. And yeah, I'm not a gambler, but what are the odds actually to suffer from lymphoma and then get a heart failure and then get breast cancer? Well, I think the odds are quite high, but still, people are getting these diseases, both of them, and the older you get, the more chance is there that you will have multiple conditions, of course. The comorbidities and connected diseases are, well, it's a fact. So I expect to have more if I am fortunate enough to live a bit longer. But what I've learned, and I'm really keen to tell you this from my experience also being a member of the Cancer Mission Board. When traveling around Europe, I think the goals of the Europe's Beating Cancer Plan has really been useful. Because when you talk about early detection, when you talk about understanding, prevention, diagnostics and treatments and quality of life, people can understand that. And for me, politics and what we decide as policymakers, wherever we are, it should be understandable to people. They should understand what we are doing. And I think so important that we can also connect, cancer and cardiovascular diseases, and also be measuring all the things that we cannot do today. We don't have an inequality registry for cardiovascular disease, as far as I know, but we have it for cancer. So we need to be able to compare and also to see those people like me who have been affected by both areas. I also think that when we have created, cancer comprehensive centers, specialist units all over Europe, I think it's also has put the ground for other kind of diagnosis. Because we cannot do diagnostics and treatments without also helping others, of course. So when we think about how to explain a new cardiovascular plan to people, I think, if I may just suggest that, to use the framework we already have, because people should not either compete with each other, you know. Cardiology is more, you know, important than cancer. No, I don't think so. It's equal. And if we talk about equity and health, I think we need to see what I said from the beginning. The comorbidities and connected diseases is really important. The older we get, the more problems there will be. And we also need cardio-oncologists, we need people, doctors, healthcare professionals that also can treat all these people with all the connected diseases. Thank you so much.
Thanks, Pernilla. And obviously, Pernilla is forever young, but we do have an aging population in Europe suffering from cardiovascular disease at the same time as discovering cancer. So how can you make sure that the two plans complement each other, Commissioner?
First of all, the blueprint for the cardiovascular plan is the Europe Beating Cancer Plan. And we need both. But so far we've been missing the cardio plan. And I want to put next to the cancer plan, the cardio. The interplay between the two is extremely clear. Let's look at the risk factors. The risk factors, most of it are common. So when we talk about the risk factors for the cardio, of course, with this we also want to reinforce the messages in the cancer plan. And if we are able to put the new technology faster out through the cardio plan, and we can create the right framework to do that, I will go back and do the same in the cancer plan. The cancer plan is a major success, and it is here to stay. But it needs to evolve together with the cardio plan. So don't worry, there is no superiority of one over the other. On the contrary, we will need both because we are addressing the same problem with both.
Thank you, Commissioner. Well, let's look at the issue of health equity. And Igor Grabovac is here. Igor is from the Medical University of Vienna and is an expert in health equity and has been very involved in projects as part of the implementation of the Beating Cancer Plan. So Igor, your pitch.
Good morning. Earlier Fausto said we have the heart and the lung, so Pernilla and I joked around that we must be the soul then. And as the soul, I would like to talk to you about equity. And I think when we talk about equity, it's not some sort of a policy ideal, it's not some sort of a lofty goal, but it's a responsibility that we all share, that all citizens of the European Union have access to fair access to care. And I think this is one of the things that the Europe Beating Cancer Plan did very well. It positioned equity as the central point, and then all of the other activities were revolving around that central point. A lot of the things that we heard and a lot of the things that you also said revolve around technologies and new innovations in the technological area. And here I would voice caution. Technology and innovation by itself does not guarantee equity. It actually has more the ability to promote and deepen the gaps that we have between different groups. When we think about urban and rural areas, or well-resourced and less resourced areas. So this is something that we really need to keep in mind. We need to keep in mind that when we do innovation, technological innovation, we also do social innovation and make sure that technologies build bridges and not further barriers, right? Another thing that I think that the cancer plan did very well was to consider patient journeys and patient pathways and not disease pathways. And this maybe sounds like a semantic change, but it's a very big change. Making sure that equity is something that we really take into consideration throughout the whole of the patient journey, meaning from primary prevention, if we're talking about obesity and smoking and so on, all the way to early detection, knowing your numbers, diagnostics, treatment, and then later on rehabilitation, quality of life, survivorships, and so on. And that also means that we need to integrate care throughout systems and throughout silos so that people are supported throughout the pathways. I think Europe here has the opportunity to really lead by example. And I know everything that we've heard about you, at least, is that you're a very practical person. So the question is, how do we practically implement equity? Unfortunately, for that, I have an easy sentence, but not an easy solution, and that means participation from patients, from patient representatives, in not only creating evidence, not only in scientific research and programs, but also more importantly in policy. Now, I also know that nothing screams equity like having a bunch of privileged people in an Austrian village talking about equity. But I think we can use this privilege and this momentum that we create here to make sure that the cardiovascular plan is really another wonderful piece of European policy that will really promote the idea of healthy and equitable Europe. And that's it.
Well, you talk about equity, I talk about personal choices. And I think we're talking about the same thing. We're talking about the same thing because to me, it's more about getting the technology to the people to create the personal choices that they don't have currently. You call it equity, that the poorer part of the society has less access. Yes, we see that. In terms of public health data, it's apparent. But I don't think that technology itself will limit equity. On the contrary, I think it will improve it. If we are able to create new tools with which your family doctor is able to give you a personalized overview of your biology, of your risks, and of your future patient route, then I think we are making much more equity than with any social measure that we could come up with. Because it will mean that this will reach everybody. And this is what I mean when I'm talking about personal choices. And if we screen, for example, many more people, it will mean that we will reach much more people also with treatment. This is also a very important element. So I'm not worried about equity. I think that equity will come only now.
And I know from previous conversations we've had that you're hoping that the cardiovascular plan can address specific cardiovascular disease issues relating to women, for example, yes. which is some. So let's go to the news desk. I know some of you have been sending questions to our young Gastiner, Sophie Miller, from the European Society of Cardiology. Sophie.
Yes, thanks. Do you hear me fine? Yeah. Plenty of discussion, plenty of comments online following really interesting discussion. I pick a couple of comments and then a couple of questions. There's a lot of support, of course, for the cardiovascular plan, but highlighting that it's not only a health strategy, but an economic strategy, that the plan will increase workforce productivity, decrease long-term health costs, and that linking to what Igor was talking just now and yourself, that in order for this to be a success for all, that solidarity, fairness, and equity has to be embedded within the plan. A few comments on the importance of public-private partnerships, and then some questions. So, as you just mentioned, knowing your numbers, how can we make that accessible to all, especially those that have difficulty in accessing healthcare? And then an interesting question too, perhaps, is talking about AI-powered personalized prevention. This needs good data. So I quote, garbage in, garbage out. So how can the plan support good data as well?
Well, I take the first two as comments. Yeah, the third one is a real question. Yes, for this plan to work, but also for the cancer plan to work, we will need much more data, which means that we need to generate more data. So we need people to see their doctors much more often. And we need to screen people much more often. This is also, I think, a public health must. A public health must, because otherwise we will never be able to improve the basics. And it also means that we need more cooperation also from industry to generate this data. Because for them, it is the raw material of the future. And for the people, this will be the cure. So let's agree with industry that they will chip in generating this data.
Well, that's a nice comment to end on, Commissioner. Commissioner Verhey needs to leave us. We're going to continue the conversation with our expert panel and all of you. But please, ladies and gentlemen, please thank for his time, Commissioner Oliver Verhey.
Thank you. Thank you very much.
So, as the Commissioner and his team leave, just wanted to ask our panel their reactions to what the Commissioner said and maybe to add a little bit on their pitches that they shared with us and with the Commissioner. Maybe start with you, Susanna. What take did you get from what the Commissioner was saying?
I think I am immensely reassured, actually, that the full expanse of what we've discussed are being considered, and clearly being considered in a very serious way. I like the concept of it's not cancer versus cardiovascular. You know, it's about people. It's about keeping people well, and so people can live good and healthy lives, and trying to see what we can do to empower that, and not in a, as we would say in England, motherhood and apple pie kind of way, but doing it properly. So investing in research, thinking carefully about access, not pitching one disease process against the other. That's not how life is. And also facing up to the realities of vaping, smoking, ultra-processed food, too much sugar, and that if we don't act, then it's going to be very bad for future populations. They're not going to live healthy lives because we've allowed population to drift in the direction that it has done. So I feel reassured that this is all being considered in a very careful way and a very systematic way, and that we're not pitching one disease against the other above everything else.
And can I ask how the European Society of Cardiology can help the Commission in the implementation of this? Because I know from the Beating Cancer Plan experience when I was at ECO that actually the Commission ends up relying on expert medical societies and patient groups to be able to understand, to get into the detail of it, because people working in the Commission don't necessarily have that level of expertise.
So that's a great question, Mike. Thank you for it. So to my mind, there are two parts to it. One is the partnering with experts across a number of specialties. So the European Alliance for Cardiovascular Health, of which the ESC is part and secretariat. But again, not pitching one disease against the other, but we're all in this together. So it's advising at expert level and at patient level. So the plan is as good as it can be. But the second, and I think the most important thing, is easy to talk, but then how do we turn that into action? And the European Society of Cardiology is made up from the national cardiac societies. So these are the people who are the experts and can influence locally to implement what needs to be done through the national cardiac societies, and opening up the dialogue between each individual president of every cardiac society and the politicians and the people who hold the budget. And to the comment about equity and importance, I just hope that the cardiovascular health plan gets the same budgetary considerations as the Beating Cancer Plan, because it is equally important.
Okay, well, fingers crossed on that. Susanna, what was your reaction to what the Commissioner said? I thought your intervention was fantastic, linking the heart and lung, and offering the support of the lung community, the patient community as well. So what was your take on what he said?
Thanks, Mike. I think he picked up a little bit more than he has heard so far on potential more benefits to be gained. If you also look at the breathing-related issues, lung health-related issues. So I hope that is the case. That was something that I picked up, and I hope we will be asking to know more about that. However, I did not hear a direct promise to actually look at the Tobacco Products Directive. I also didn't hear a direct commitment about including respiratory infections as such into the plan. So I guess he might need more evidence and more, I mean, what he could win by doing that across population health, and this can be measured, and then it can be communicated as a success for the plan. I also think that he heard a little bit about the systematic health checks, that you can win more in that if you are including lung health checks for those at risk. So I am quite hopeful, and I leave it to you to comment on the health equity, because indeed that's something different than let's say trying to achieve equal access. Equity is quite a deep concept, and I appreciate that people want to do things rather than I mean, talk about things. So this is what I appreciate. So I think there are some wins there to be achieved.
Yeah, you provoked a reaction there, Igor, from the Commissioner when he was answering your points on equity, and particularly about technology. What did you take from that?
Well, I mean, I would say now that he's not here, we can speak freely, but it's broadcasted, so I need to behave. And every time I get invited to a panel, I need to be cautious, because it might be the last time that somebody invites me to talk openly about things. I think there's a misunderstanding on equity versus equality, and I think he talks more about equality rather than equity, and I think that might be one of the issues. I really like the idea of him voicing the need that people need to go to the doctor, and that he wants to make sure that the access to healthcare is achieved in an equitable way throughout Europe. I think that's a very positive note for that. Is that achieved through technological advancements or investments into policy and changing laws and situations in different European countries? That's a different topic. But if that really is, something that he wants to achieve, then I need to emphasize we have 1.2 million people who are homeless in the European Union. We have millions of people who live with very strong mental health illnesses who cannot achieve access just like that. So there are various barriers that we need to consider if this is really something that we want to achieve as a goal, right? Not to mention people who live with multimorbidic conditions and have different difficulties in achieving things. And I liked what Susanna said about risk factors, but moving from the individual risk factors, not placing the burden on the individual patients, but on the structures, and asking how the structures can help in reducing those burdens and those risks.
How come everybody claps when you speak, Igor?
It's the local team concept.
Yeah, I'm from Vienna, so that's
starting to get to know a bit annoying with your Austrian fan club here.
We don't care.
Fausto, you've been working towards a cardiovascular health plan in Europe for as long as I've known you. Yeah. What was your reaction to what the Commission
said? Well, you saw it, and was thanking him and the Commission. I think I was actually very well. I'm like Susanna, I was well impressed. I knew some of his ideas and of the current Commission. I think this is actually a very important moment for Europe. Now, the big question, as always, and the big challenge is how we can translate this into action, into practical terms. How much all of this can actually be done. And for that, we need to increase support in all what is said about getting more data, people going more to the doctor, but that's not enough. You need to have resources to deal with that, to work with that. So you need more support to research. And when we talk about research, all types of research is not only let's say the classical scientific research of knowing about the molecule or knowing about the disease. It's about the new aspects that we're dealing today, with using AI, using all new technologies that can actually help us to not only collect the data, but then manage the data and use that data to translate into real action. So I'm optimistic. I think it's clear now that we have a plan. It's going to be, I'm sure, because it's a commitment, and that the politicians do well. If they will, I'm sure it will be delivered. The big question is how we can translate that into action, and that's where all of us, because this should be a commitment by all the society, as a whole. It's not only about scientific community or medical community or patient community. By the way, patient community are all of us, because all of us are potential patients. So it's all of us. It's about local politicians, it's about governments, about decision makers, about the community as a whole, to engage in a process that we can be more successful on implementing what he also said, and we keep saying that also. We know a lot already. The problem has been, and that's the big gap, how we can put that into action. And I think that's going to be our challenge for the next few years.
Yeah, and during the Beating Cancer Plan, implementation, first stages of implementation, we were often saying the devil's in the implementation, and one of the benefits of the Beating Cancer Plan was having the inequalities registry, so you could point to, why does one member state have much higher HPV vaccination rates, for example, than the neighboring country? Oh, because they've got a better system of implementation. So there is an opportunity there. I thought, Pernilla, it was very interesting that you provoked an answer from the Commissioner that I've never heard him say before. And it's great to see Elisabetta Zanon, CEO of the European Cancer Organisation, with us this morning. He was quite clear, wasn't he, that there is no hierarchy on the two plans. I've never heard him say that before, because of his passion for the cardiovascular plan. I thought that was interesting. What did you think?
Yeah, I was very happy to hear that, because people well, they have been worried about, when we see that, both cancer and cardiovascular diseases needs to be addressed. No one is telling anything else. But I think what has been built up and it will still be building for many years ahead, from the Europe's Beating Cancer Plan and the Cancer Mission with Horizons, different programs and funding. I think it has been useful for all member states to actually be able to understand that we need to work together. As Fausto was saying, we need to make it a concern for the whole society. But what I really like to also, take as a promise maybe from the Commissioner is also what I've seen when I have been traveling around Europe is that we need the trust. We need to have trust in healthcare, in our democracy, in our healthcare system. Otherwise, it will not work whether we have plans or not. Because if people are not going to screening because they don't trust the healthcare if they get the diagnosis, then we have problems. So we can sometimes offer access to healthcare, but if they don't trust the outcome, it's really a problem in some, I would say, not well, in general member states, but in some areas. And we need to build trust that it will work, and we will still see innovative medicines coming to the market. We need to see that new diagnostic tools will provide us with new guidance and knowledge and so on. and also to be very clear to the society and citizens what we are doing, because people are not aware enough about cardiovascular diseases or cancer.
Yeah. Susanna, you said in your pitch about this thing of, sorry, we've got two Susannas on the panel, which is very confusing. Susanna Price, you said in your pitch, you can't tell your risk factors just by looking at someone, right? And you're an acute cardiologist that deals with some pretty tragic situations, including with young people. Would you mind sharing a little bit of your experience about that fact that we didn't know that somebody had an issue and the real human side of this situation?
Yeah, of course. So I think there is a sort of pervasive still belief that cardiovascular disease is owned by older people, usually men, who smoke too much, drink too much, eat unhealthy food, and this is what cardiovascular disease looks like. But that's not entirely true. So part of my job, I'm an intensive care cardiologist, and I'd love it if my intensive care had no cardiovascular patients in it at all. That I would think would be fantastic. But the trouble is you don't know. So the traditional risk factors we know about, but there are other people who may be very young and have cardiovascular disease. So we're currently looking at one of the most lethal manifestations or presentations is where patients or people turn up and they have cardiogenic shock, so their heart is catastrophically not working, and it can be completely out of the blue. So they may get a viral infection, speaking to the vaccination side of things. It may be related to pregnancy, it may be just related to a fast heart rate, and they may be 15 years old, 16 years old, 17 years old, and sometimes will present and the treating clinicians, even when these people are catastrophically ill, they say, well, you're too young to have heart disease. You're actually never too young to have heart disease. You know, you can be born with cardiovascular disease. So the treating clinicians, as well as people, their perception of cardiovascular disease is probably skewed to one end and not really looking at the whole population. And we see it so if I turn on the TV in the UK, we have Great Ormond Street, which is a hospital for sick kids. And usually you see the pictures of the little babies who are being treated for their cancer. You don't so often get that perception for cardiovascular disease. And I think it's incumbent on all of us to be aware that this is not a disease that only affects you by the time you get to 60. Actually, your risks for cardiovascular disease start before you're even born and then are built on throughout life. And then even young people can present and be catastrophically ill, and you can't tell from the outside. They may have been completely well the day before. So we need to change it up a bit with awareness.
Thanks, Susanna. So questions from the floor. We've got some microphones, I think. I know Elisabetta would like to ask a question.
Thank you, and thank you for this very interesting discussing in the panel. And I really think the know your numbers is important. And I think the numbers here should be 1 in 2 and 1 in 3. 1 in 2 have poor health literacy. That means that they will not be able to get the effect of what we apply for them. And 1 in 3 patients with cardiovascular disease have mental health issues after their disease. That's at least for ischemic heart disease and maybe even more for stroke. So I thank you, Susanna, for highlighting this shift we need from individual to systematic perspective. If we really aim to reduce social inequity and improve equity, we need to include all citizens and not just the half of us sitting here with very good health literacy. Thank you.
Thanks very much. Let's go to Elisabetta next. Then we have a question here and then there. Elisabetta.
Yes, thank you very much. I am Elisabetta Zanon. I am the Chief Executive of the European Cancer Organization and also formerly Advocacy Director at the European Society of Cardiology. I have a comment question related to the synergies between the European Cancer Plan and the forthcoming CVD plan. Of course, there is prevention. This is an obvious one in terms of some of the risk factors being the same, but there is much more than that. There is, of course, elements related to screening, early detection. We do a lot of work in cancer around screening, of course, and there could be, in my view, opportunities to try to use some of these initiatives also for cardiovascular disease. So, for example, if we think about screening for lung cancer, a lot of cardiovascular problems are detected when you do this sort of screening. If we think about mammograms, some markers for breast cancer and for cardiovascular disease could be identified. So how could we try to leverage somewhat these opportunities emerging from early detection initiatives that we do for one disease, also for the other disease? And then finally, in relation to treatment, there is the element of cardio-oncology. I remember at the time I was at the European Society of Cardiology, it was an important area. Cancer treatments, of course, they have toxicity for the heart. We see patients then developing heart failure, unfortunately. What could be done as part of the cardiovascular plan and the cancer plan to try to address these side effects related to treatments?
Thanks, Elisabetta. We've got another question here, and then we'll come back over here. Thanks.
Thank you so much. My name is Natalie, and I'm working as the youth advisor to the Ministry of Health of Ukraine. And I would like to start with a short comment. We were talking about the gap between technologies that are existing and to implement them on the ground. So, in my opinion, we talked a lot, but we haven't mentioned young people that should be empowered to implement those new developments on the ground, because I'm working as the medical resident at Interventional Cardiology Department, and I am the person that faces the new technologies first, and then I'm coming to my older colleagues to explain them. And one of the excuses that we usually hear how to implement developments on the ground is lack of financial support. Let's imagine that tomorrow we're going to have enough money to implement them on the ground. So what's going to be the next problem that we're going to face during the implementation on the ground, all the technologies? Thank you.
Thanks for being here, especially from Ukraine. The last question is here, if we can, and then we'll just hear. Thank you very much.
Hello, and thank you. I wanted to point out a few things I picked up. We talked a lot about the importance of knowing the numbers. But what are we doing to prevent those numbers from going high in the first place? And I think the revision of the Tobacco Taxation Directive is one of the things that it is in the right direction, but we need to have other systemic policies in place to act on different risk factors, such as alcohol, ultra-processed foods. And another risk factor, which I had hoped to hear, but I was really surprised that I did not hear, was air pollution. Air pollution is responsible for up to 28% cardiovascular disease mortality in Europe. And we did not discuss it. But it is part of the Beating Cancer Plan, and the Commissioner mentioned that the Cardiovascular Health Plan will also follow that blueprint. So I hope that this point will be mentioned as well, and it was in the Beating Cancer Plan. What I don't hope is for all these dossiers to get delayed like they did with the Beating Cancer Plan, or like the farm to fork strategy just swept under the carpet. Thank you.
Well, thanks for that. I wish the Commissioner had been here to hear some of that. Yeah, I think you make a very good point, very good points there. I think, yeah, Fausto, yeah.
Something about, because I think this is very important. And actually the World Health Federation last year Every year there is the World Heart Report, which is focusing on a specific topic. And last year was about air pollution. You know, we are very much aware of that. And I totally agree with you, and it's being put on the agenda. It's been slow, but at the World Heart Federation, for instance, there is a group dealing with air pollution and climate changes and the impact on cardiovascular health. It's not only about disease, but about health. And I certainly think that it's going to be more and more relevant in Europe, although, as we know, this is a problem that affects the globe. But in Europe, we also have to take care of that. Of course, we didn't have time to talk about everything, but this is a very important topic. And just one additional comment on what that colleague mentioned. I think one area that we also have to push is the fact that cardiovascular disease or conditions are very much responsible for dementia. And this is something that is becoming also more and more relevant to explain why do we have to treat hypertension. You know, one of the problems, as you know, that we face, we only have about 20% of the people who know they have hypertension being controlled. And one of the things that we may use as an argument to improve patient empowerment and patient engagement or population engagement is the fact that a lot of dementia is related with vascular conditions. And this is something that if we do prevention on cardiovascular factors, we will also not only prevent heart failure, atherosclerosis and so on, but also dementia. And this is a message that should go across.
Susanna, would you like
no applause, come on.
Yes.
No, just kidding, just kidding.
Yeah, I wanted to briefly about the air pollution because from the respiratory patient community, I feel ashamed that I didn't mention it. And the reason was because we were asked to make a pitch for the commissioner and to include things that are not presently in the plan. So that's a super important point. Of course, it's across the board. Air pollution is one of the most important prevention that we can do. I wanted to briefly mention about the importance of, there was a question about how to have the synergies about the screening and health checks. One example is that in the present lung cancer screening, they are mostly finding COPD patients, okay? So that's who they are finding. So there are so many cross benefits if you have good screening programs in place.
Thanks. And Pernilla, you wanted to make a last comment as we close?
Yeah.
Okay.
Well, I think the World Heart Federation did an excellent report about cardiovascular diseases and air pollution, I think 2 years ago. Yeah, so that can be used as a blueprint as well for other diseases, I guess. But also to mention that the cancer mission is one of 5 missions, initiatives by the European Commission. And all the other 4 are about climate changes and environmental issues that also are affecting health. And especially in that case, we also have that cancer mission then. So we're working together with all the other missions to also see what we can do in the climate changes field and those environmental in the different countries. But to go to your question about implementing and also address young people, I think the difficulties with all ages, I would say, is that when you're not affected by yourself or you're someone in your family or a friend and so on, you are not interested. You have to be affected, very, very close to your heart by any disease to actually be involved and to fundraise and to work, create activities and to learn more. So that's the problem we have, I would say, in all ages, everywhere. So when you do have the engagement, we can, create wonders, actually. But if we don't, it will happen nothing. So, yeah, the civil society do play a huge role in this. And I really would like to see more associations, organizations work together in this.
Thank you, Pernilla. Well, I'd like to close by thanking all of you in the room for being here. Looking at the camera, to thank everybody who's watching us online. Thank you for joining us. Thanks to Sophie at the news desk for one of our young Gastiners from the European Society of Cardiology. And I'd like us to show our appreciation for an excellent panel, Susanna, Fausto, Susanna, Pernilla, and Igor.